Hello, I'm Dr. Andrzej Dmitriew.
And I'm Dr. Marjan Farid.
For IOL power calculations and beyond, untreated astigmatism can wreak havoc on even the most flawless cataract procedures.
That's why it's all about preoperative assessment, including power calculation and lens selection. And that's what we're talking about in this video, with practical tips and tricks for mastering these keys to cataract success. Andy, how common do you think astigmatism is in your preoperative cataract practice?
So basically from studies, we know that when it comes to patients with any significant level of astigmatism, and I would say even 0.5 diopter of astigmatism can be significant in many cases, that goes up to like 60% of cases, depending on the studies, but between 50 and 60% of patients are potentially involved in a astigmatism group. Which means that if we consider the most modern and updated IOL solutions, I mean like the best lens platforms, including multifocals, you can expect that 0.5 diopter of astigmatism can be a real issue. So it's more than half of the population.
It really is. I don't think everyone understands that even a half a diopter of astigmatism can have a significant decline in visual quality. So can you tell us a little bit about the impact of different types of astigmatism? What are you looking for and how do these impact the vision?
So generally we know that if you assess the corneal quality, it's pretty important to know the steep axis, because we know that in patients with steep axis within the 180 meridian, we see that there's more dependency on the potential role of astigmatism on the final outcome, especially when it comes to multifocals. And even 0.5 diopter of astigmatism can decrease the final outcome by 2 lines, which is a problem in multifocal patients.
Yeah, absolutely. And I think we have to remember that the posterior cornea contributes additional against the rule refractive astigmatism, again at that 180, which is kind of the worst astigmatism to have. So, you know, my rule of thumb is over-treat against the rule astigmatism if you're using anterior keratometry measurements alone. What about regular astigmatism, irregular astigmatism? How do you sort of figure out if the patient's astigmatism is regular enough to treat with something like a toric lens?
So we should treat regular astigmatism only because this is how the registration for the toric lenses. But we know that there are lots of irregular astigmatism patients with stable corneas. So obviously it's a different story and it's always an individual case, but I don't have any problem in treating patients with irregular corneas if I have a history of stable cornea.
I completely agree with you. In my mind, I sort of divide irregular astigmatism into treatable irregular astigmatism, things like lumps and bumps on the cornea, where you can treat those, bring the patient back and look for regularity of the topography. And the types of irregular astigmatism where you can't fix them, like keratoconus or post-refractive irregularities on the cornea. And on those cases, as you said, you look for stability. I look for things like preoperative manifest refraction, where if it's stable and if they're doing well with manifest refractive cylinder, then they may do very well with toric lenses as well. If they don't, and they've required a rigid contact lens, for example, then those patients will not do well with a toric lens.
As we mentioned, that preoperative assessment is such an important part because that induces potential errors after the surgery. Could you tell us something about the common techniques for measuring the topography of the cornea? Which techniques or systems do you find most reliable in practice?
So in the preoperative setting, you know, I like to do at least 3 different types of diagnostic measurements, calculations on the cornea and look for congruency. So I use my IOL master. For me, my biometer is my IOL master. It gives me really valuable keratotomy readings. I look at my topography, tomography. I use the pentacam. And then I also use a third measurement. Sometimes I use the manifest refraction. But again, I like to see congruence because we don't want to base things on lenticular astigmatism. We really want to hone it down to corneal astigmatism. I also like to use sometimes an aberrometer like the eye trace. You know, finding an axis that's within a certain degrees, 5 to 10 degrees between these is important. Looking at amplitude that's consistent between these measurements. And once I feel there's consistency, then I feel confident about treating that astigmatism with a toric lens.
So how often do you consider seeing the patient twice, just to be sure that the actual magnitudes and the meridian are repeatable?
Yeah, so certainly if on the first round they're not, you know, the number one cause usually is ocular surface disease, dry eyes. So I really, you know, sometimes patients are in contact lens wears. I'll really aggressively manage dry eye disease before, especially if I see incongruencies. I'll send the patient home, bring them back 2 to 4 weeks later, and repeat measurements.
So when measuring the biometry of the eye, what are you hoping to determine about the level of astigmatism? What can the length of the eye, the curvature of the cornea, and the depth of the anterior chamber tell you about the patient's astigmatism?
So that's a great question. So we're looking at the type of eye we have, certainly. You know, things that for me might play a factor in my decision making. If I have a very long eye, if this is a high myopic patient, there may be additional stretch on those zonules. And in those cases, I just think ahead intraoperatively, perhaps using something like a capsular tension ring to maintain zonular stability and to prevent constriction of that capsule that might long-term move my toric lens.
How can you use the primary measurements from corneal topography to detect and classify cases of astigmatism?
Yeah, so I think topography really has become standard of care. Some kind of topography, tomography in all preoperative cataract patients. You really need to look at your cornea, look at cases where there may be irregularity. You know, I have a good case where a good friend of mine, a colleague, actually brought her father in for assessment for cataract surgery. He was in glasses all his life, had about 2 diopters of astigmatism in his glasses. She wanted a toric lens. He had never had a topography. We did a topography and found out he actually has keratoconus that was undiagnosed. And you know, I think you have to do topography because these cases would otherwise go missed.
And I think it's so useful to see that the biometry machines are getting topography incorporated in the software so that you can see both the parameters of the anterior chamber depth, axial length, K readings, and a small map, which helps you a lot when it comes to finding the correlation between these two, right? And finding out the quality of the cornea as well.
Yes. How about modern IOL power calculations? Is there a specific formula that you use for toric calculation?
I would say that it's like 2 aspects of calculating a toric lens. And in my hands, it's always the spherical power calculation is a separate thing, and then toricity. So first of all, even if I'm very effective in treating or correcting astigmatism, and I wouldn't be that precise in terms of spherical refractive error, I wouldn't be happy. That is why I consider the use of 4th generation or effective lens position based formula as the first choice. So that's why it's a combination of Barrett Universal 2, both with anterior and posterior surface. And at the same time, I'm still using a balance of Hygis, which I still love. And sometimes you just want to consult like Holiday 2, so a little bit older formula, but still up to date regarding specific conditions. So that's on the side of spherical power calculation. And then I'm using both Barrett and Hygis toric calculators when it comes to the final outcome of toricity correction. I'm more likely to tend towards Barrett toric calculator, but it's just personal preference.
No, I completely agree with you. I think you have to use modern formulas, really. I like to also see a spreadsheet with the different formulas and take a look at that. Sometimes there's there's platforms that can be used, such as Veracity, which can take all the measurements from the different diagnostic modalities, put them together, and then tell you what the lens power is based on different formulas, and so the surgeon can choose. It also helps with sort of toric calculations and toric choice. But yeah, I think modern formulas are really the key. And using posterior corneal measurements in your calculations. So in the next episode, we'll be discussing the precise alignment and management of residual astigmatism and barriers to the adoption of toric intraocular lenses.
So we hope you'll join us for more clinical pearls on how to optimize your patient outcomes and take your astigmatism management to the next level.